Hello, and welcome to another of our sessions of Digital Slide Review and Sign Out, part of the Digital Anatomic Pathology Academy. I'm Dr. Louis Hassel, Professor of Pathology at the University of Oklahoma, and I'm glad you could join us today. Our case that I'd like to share with you comes from the realm of GI pathology. It's a characteristic case and one that we don't encounter all that often. So the patient is an older woman, about 70 years old, who has been found to have a cecal mass presenting as most mass lesions would, with either some form of bleeding or partial obstruction seem to be localized radiographically to the area of the cecum. So just in general, an older person with a mass in the cecum, most of the time that's going to be neoplasm. And of course, it can be a large exophytic polyp, or carcinoma. This is a rather frequent location for lymphomas as well, so you should always keep that in the differential as you think about these cases. But most of them are going to be of colonic origin. Now, there are cases where appendiceal lesions, especially very mucinous lesions, can present as a cecal mass, either due to direct extension or confusion radiographically. But not to be overlooked should be some of the non-neoplastic causes of mass lesions. Granulomatous disease can present as confluent masses, and depending on their socioeconomic background, thinking about TB or Yersinia as possible etiologies for the mass lesion is important. Likewise, Crohn's disease, either as a de novo presentation in an older patient, rather unusual but not impossible, should also be on your differential. And then, of course, there are various extrinsic masses which can masquerade as primary tumors in this location. Liposarcomas, desmoid tumors, inflammatory myofibroblastic tumors, among others. So our patient came to resection, and the lesion would have looked something like this. So this is taken from the web, but obviously a mucosal tumor is a mucosal tumor is a mucosal tumor. They all look fairly similar, fleshy, raised lesions with varying degrees of ulceration and distortion. So on microscopic examination, this lesion had a mucosal component, which you can see nicely here with areas of ulceration and extension to the surrounding tissues. Now, note we have a fair bit of inflammatory tissue here, or either extension of the tumor. But we'll focus first on the surface lesion, and you can see here a nice area of erosion into a very, very blue tumor. So here's the surface necrosis, obviously the cause of bleeding or those sorts of symptoms. And then looking more closely at this tumor, you see there's a nice admixture of very high-grade appearing cells, somewhat amphiphilic cytoplasm, big nuclei, macronucleoli, a little bit of nesting and clustering, but no obvious glandular differentiation. So this really looks very much like an undifferentiated carcinoma. And indeed, initially, that was one of the terms that was applied to this lesion. Looking around, though, I mentioned the inflammatory cells, and we'll see, actually, if you were to stain, that there are a fair number of smaller inflammatory cells admixed with this, so-called tumor-infiltrating lymphocytes. And as we have learned in other sites, that's oftentimes a marker for mismatch repair defects. Which we'll discuss here in just a minute. But we see this associated inflammatory reaction fairly robust here at the edges of the tumor and surrounding the adjacent tumor. It extends deeply into the subjacent tissues. There's maybe a little suggestion that you have some mucin formation here associated with it. A few mucophages, as you can see here, and small clusters of cells that may be associated with mucin, or at least a mucin-like necrosis. So that probably takes it out of the realm of lymphoma or metastatic melanoma or other things that you might think of in that category. Here's another section of this lesion, again showing mucosal involvement and a very robust inflammatory reaction here. Some associated necrosis with the tumor. And again, this area, this pattern of abundant infiltrating lymphocytes associated with the tumor in this situation. Now, immunohistochemical markers are oftentimes a stumbling block for this tumor because we throw some keratins on it. We maybe do CK7, CK20, and it may turn out very likely to be negative in most cases. A small percentage of these tumors are positive. However, when we do a calretinин stain, this is what we see. So this is a nice positive calretinin staining, whereas the keratins were negative. And also the CDX2 was negative, as is often the case in this tumor. So is this even a primary colonic adenocarcinoma? Is it a colon tumor? Well, it is. Here we can see a little bit of the CK20 in the lesion, just a smattering of positivity in these lesions. But it's not uniform, and very often the tumor cells will have a variable expression for these markers. The other thing I mentioned, of course, here was the infiltrating lymphocytes, and so when we get down to doing MSI or mismatch repair testing, we discover a picture that looks like this. So here's the stain for PMS2. And very characteristically, we've got all of these tumor-infiltrating lymphocytes are nicely positive, but here you see the tumor cells are these little ghosts, nuclear ghosts, and little pale granular cytoplasmic staining that is indicative of non-reactivity. And so many of these tumors, if not most of them, are mismatch repair deficient, usually for MLH1 and PMS2. And you may ask, well, these are older patients. Is this a germline or whatever? It can be both ways. But this is certainly a very common finding that these are mismatch repair deficient tumors. So this is a nice example of medullary carcinoma of the colon, which is one of the least common types of primary colon carcinoma, accounting for less than 1%. Now, usually it is older patients that are about the age of our patient in this situation, and these are almost uniformly, as I mentioned, associated with mismatch repair defects. Not uniformly, not 100% of the time, at least in terms of our detection mechanisms. And we've mentioned the immunohistochemistry, that they're negative for CK20, CDX2 very frequently. They're also negative for neuroendocrine markers, which can be seen and could be in the differential, negative for CD45, of course, and positive with calretinin. Now, of note, even though this is a very undifferentiated looking high-grade carcinoma, these patients often have a better prognosis than conventional carcinomas of similar stage. And that may well be related to the mismatch repair defect, that these are more susceptible to treatment. Certainly that opens up various immunomodulatory or checkpoint inhibitor treatments for them as well, and that may improve their prognosis. So because of the spectrum of this, and because it's a relatively infrequently seen disorder, I thought it would be very interesting to show you a couple of other case examples. Here's a very early example, and one that has an associated adenomatous lesion associated over the top of it. And then here you see this very high-grade solid tumor here in the subjacent tissue, showing very high-grade nuclei, very amphiphilic cytoplasm, sparse, if any, clustering of the cells, and a very high mitotic rate. So that's a very early appearance and a recognized association with other polyps. Here's another lesion, again, showing this. Now, many times these tumors are right-sided. It's not absolute that they are only right-sided, but that is a frequent location as well. And here again, you see this very diffuse pattern, a few scattered intervening lymphocyte cells, and then very high-grade nuclei with amphiphilic cytoplasm. One more example, I believe, here, just to give you another spectrum. And of course, I'll include the link to these slides in the description so that you can come back and study them. So here's one with maybe a little bit more conventional type differentiation, a little suggestion of glandular formation. Again, high tumor infiltrating lymphocyte score, areas of more conventional necrosis, a little bit of glandular type of differentiation. So there is kind of a spectrum from totally undifferentiated to poorly differentiated with a lot of inflammatory associated cells into which these lesions can fall. I would tend to use the calretinin staining as a marker rather than strictly the mismatch repair deficiency, since there's a variety of other tumors that can have that morphology as well. So our final sign-out diagnosis for this case today, one more example. Here again, more confined superficially. And we'll give you just a rundown here again to see the sort of pattern of infiltration here. This one has a little bit less in terms of inflammatory cells, but I think you can see that as we come into higher power, that these nodular rounded areas are in fact infused with abundant lymphocytes. And then you have these cords and chains of high-grade nuclei associated in between the inflammatory cells, which in this case also includes a number of eosinophils. Okay, so our sign-out diagnosis today is medullary carcinoma of the colon and mismatch repair deficient with loss of MLH1 and PMS2. So I hope you enjoyed that little brief discussion and insight back into medullary carcinomas of the colon. If you did, please hit the like button there and also subscribe to the channel. It helps us to get our word out to more people. And we hope that it helps to alert you to similar topics that will be instructive and helpful for you as we continue to share some of the great cases that are available on the Digital Anatomic Pathology Academy site. Which is, of course, a member benefit for those of you who are members of the Digital Pathology Association, which is free to trainees and people in developing countries, and is also very, very affordable for those of us elsewhere. So until next time, thanks so much for joining me.